And let's go ahead and do every term I do this. Every term I go through, I look at the last HESI. I look at concepts that were there and say, okay, what do I need to bring and talk to you about in a different manner? So as we know, HESI is the entire nursing program. That means from infants to adolescents, that's all the behaviors, that's all of the diagnoses. And of course, there's those theorists. So it's a lot of different stuff, that we are looking at. So let's start looking at things a little bit differently. So here's one of the things that you've heard me say if you've listened to any of my reviews or you're in my class: nutrition, nutrition, nutrition. What are some things we have to know about nutrition? Well, we do know you need nutrition to grow and to be cognitively aware. And if you don't get nutrition, there's going to be problems, right? Well, let's put that into a child that has a diagnosis like irritable bowel syndrome. That child's going to have a lot of diarrhea or nausea or vomit or something. They're not going to get nutrition the way that they should. What are we going to be looking for? We're going to be looking for that height and weight, right? Every visit, but also developmentally, are they where they need to be? Or is this due to a child losing nutrition? Now, take it and put it as an infant losing spit up, GERD, reflux, that gastroesophageal reflux disease. So now you have a child who is spitting up. Infants have a stomach that's this big, right? You put that little bit of spit up out, they are losing a lot of their nutrition. So what do? We're going to just thicken it. Now, you're saying usually we don't feed infants till about 5 or 6 months old. And we do it one at a time every 4 to 7 days. We know that. But why do we put rice cereal in an infant's milk or breast milk? Well, if they prevent the spit up, they're keeping calories down. And even if they don't use the rice cereal as nutrition and it comes out in the stool, they're gaining nutrition. And that's what the point of this one is that we put rice cereal in it, it stops losing nutrition. How do we know it worked? Less spit up, child's cognitively aware and gaining weight. As simple as that, okay? That's how simple as you need to think these things. Okay, osteomyelitis, nutrition. Well, osteomyelitis is an infection in the bone. So number one, you have an infection, and number two, it's in the bone. So again, when we're talking about nutrition and we're talking about a diagnosis, what are things high in protein and healing? Well, here we go: vegetables, whole grains, breads, low fat dairy, beans, lean meat, fish. This is high in protein, helps with healing, and it will help with that disease process. Another thing, nutrition. Doesn't matter, children, infants, toddlers, preschool, school age, adolescents, adults. It doesn't matter if you have a problem with diet. What's the first thing you want to know? What did you eat yesterday? What did you eat today? Give me a 3-day diet. Diet histories. Give me a diary. Give me that diet diary. And then I can look at that. I can say, okay, well, let's look at this diet. Let's see some changes that we could make that would improve, either increase or decrease calories, depending. If it was overweight, we're going to decrease calorie. Maybe they're drinking too much juice, or maybe they're having too much sugary, whatever it is. We could change diet by just looking at what they had. Another thing with obesity in children, a good question is, are they up and out and moving around? Is this the child that's on the iPad all day, or do they go outside? Do they play? Are they just big, and heavy, but they're very active? There's all different sorts of reasons why children are obese. I mean, we have families that are bigger. But again, obesity, one of the big things we could do is increase their activity level and asking questions like, are they at least in PE in school? Do they have that? Many schools do, some don't anymore. Another thing with nutrition, we talk about nutrition and we talk about conditions that they can't eat certain sort of things, okay? So Celiac disease. What is celiac disease? This is wheat, rye, barley, oat allergy. Let's just call it that. What do I mean by an allergy? It means that the small intestines, when this stuff gets into it, it goes into spasm, causes severe pain, cramping, and also can cause diarrhea and nausea. So, what is our job in a child with celiac? Well, just because we put celiac as a listing on a nutritional tray to send to dietary, when that tray comes up, let's say they've given them some full liquid. So they send up soup with crackers. Now, what would you take off that tray? And these are things as nurses we should look at, be aware of. Crackers aren't good. Let's take it from the tray. All right. So again, we're applying the knowledge of celiac disease and now looking at it as a nurse. Okay, what are they eating? Are they eating the right stuff? Oh, let me take that off before they get it. Another thing is children, infants, and that's a great picture, that bottom middle picture. That is thrush. That is white, it's thick. You can't scrape it off, and it actually is very painful if you try to do that. This is only cured with medication. This is not, cleaning the nipples. This is not washing the mouth out. It needs
Yes.
nystatin. And then remember, it's on a cotton swab and swabbed on an infant. We don't swish and swallow. That's older people. We don't put a squirt in a syringe. They won't put it where it needs to be. Just a swab, put it on there. Another thing let's just talk with infants is you have a child is up all night long and screaming and not sleeping. One of the things, believe it or not, that it could be, it's not that they're hungry. It could be as simple as a diaper rash. Diaper rashes hurt. So making sure that if we do have a diaper rash, that we do treat it with the appropriate whatever medications they want. And again, as I said, nutrition, infants start at about 6 months old. We only put one food every 4 to 7 days. And the reason why we split out the amount of food that we're introducing is because we're looking for allergies. Children can be allergic to the strangest things. So one at a time so that we know what to avoid. Okay, now let's start with infants. So, there's all these developmental things, and what do you need to know? Well, with the questions that you'll see on HESI, knowing the age and knowing what they should do, there's generalities. There's not these big knowing that you grow 3 inches, at when you're 2 years old every year. No, it's more like if you don't see growth or you see less than, those are the type of things that you'll be able to pick out. Now, head circumference on an infant, something we do every assessment on any infant in a hospital. What if we see if it's getting bigger? Well, number one, what do you think is happening if the head circumference is getting bigger? Well, hydrocephalus. How do you see extra fluid in an infant's brain? That good old fontanelle. Remember, that fontanelle is going to tell you a lot in infants, all right? So always remember, head circumference getting bigger, some sort of head injury, traumatic brain injury, always look, fontanelle is going to be there. Another thing with infants is they need to be able to self-soothe themselves. And many infants are born, for instance, let's say you're a transesophageal fistula. That's that really bad one, where there's a tube between the esophagus and the trachea. So if they swallow, where does the food go? Goes right into the lungs, right? So this child cannot eat. How is this child going to soothe themselves and comfort themselves? This is a child, please give them a pacifier. As simple as keeping their developmental level on track is as simple as giving them a pacifier so they can learn to self-soothe, because that's what they should be doing at this time. Another question we're going to be getting from parents is, my daughter did this, but this child's not doing this at the same time. What would you say? Well, all children are different. There are children that at 9 months are walking. My children didn't walk till they were 15 months and they never walked, they ran. So again, all children are different. As long as developmentally they're moving forward, and they're doing rolling over by 6 months, lifting their head by 3 months, sitting unsupported at 8 months, we know that that child's right about where they should be. Another concern with infants, whether they be a congenital heart, whether it just be a premature child, problems with feeding difficulties. What if you had a child that's what we call failure to thrive? It could be a metabolic syndrome, it could be a dietary issue. There could be all things that are going on. Failure to thrive. What does that mean? That means a child who's not at the weight it should be. At 6 months, they should double their weight, right? What if a 7-pound baby at birth only weighs 10 pounds, 6 months? This is failure to thrive. That is a lot of weight on an infant. How would we improve their chances of gaining weight? Well, they're not going to increase the amount of formula they can drink or milk they can drink, but if we can increase the calories, whether it's breast milk, there's breast fortifier. Breast milk fortifier adds calories for every ounce, or we can have increased calorie formulas, iron fortified formulas. So that's what we would use. Same amount of formula, so we're not increasing any of, the effort the child has to make. Okay, toddlers. Remember toddlers. These are children who are all about separation anxiety, right? These are all about they don't like people besides mommy and daddy, and they like routine. So these are really good. Toddlers, ages 1 to 3. We have to do something many times is using a doll gives them that visual and they can touch and feel those things. Remember, what you do for a 1.5-year-old is going to be different from a 3-year-old. Always make sure you're always on the developmental level of that child. Preschoolers, we can hop, skip, and jump. We can button our shirts, right? Speaking, we're going to speak at least 4 or more word sentences. A preschooler, maybe 2 or 3 words. Now we're getting up into the ages 3, 4, 5. These are those children who are going to do those 4 word sentences, and as they get bigger, 5 and 6 word, and comprehension is going to get a lot better. Now, autism is usually diagnosed right around 2 years old. There is many ways we can understand it. The one behavior that you see with children that are autistic is these what we call repetitive behaviors. They will do the same thing over and over again. I use this as an example of a clinical site where I went, where the child was not only autistic, he was down. So he was really in that cognitive level, right? So he would take a chair or a stool, and he would take like a fire truck and put it on top. Then he would take a ball and put it on the fire truck. And then he would take a coloring book and put it on top of the ball. Then he would take the coloring book down. Then he would take the ball down. Then he would take the fire truck down. Repeat. Fire truck up, ball up, coloring book up, repetition, repetition. There are many different sorts of things we can use, but this is just to show you that there are checklists that we can use that can identify possibilities of autistic children. Now, school-age children. Remember, school-age children are all about feeling good about what they do well, right? Remember, this is their industry. This is what they do well. Always you'll see Ericsson industry on these things. So, school-age children. You have a school-age child, and we notice that this child is shorter as comparative to other children in the same grade. And they looking at possibilities of treatment for being so short. Well, we just like, for instance, growth hormones. This is pituitary gland, right? Are we going to be giving growth hormones to this child, or is this child where they are? Well, the way to identify that is to look at the family members. Is the mom and dad short? The child's going to be short. Mom and dad tall? Okay, the child has a possibility of being taller. Yes, we can start then some sort of injections for the growth to get them up to where they need to be. Another thing we have to remember is not only children in the hospital, whether they're school age, preschool. Remember, these children do worry about their brothers and sisters at home, and the ones at home do worry about the children in the hospital. So opening that communication, today we're lucky. We're lucky we have FaceTime. It used to be I sent home letters or I'd sent home ribbons and bows that I'd make for my kids. But keeping them involved with them makes them feel important. The child in the hospital doesn't feel, guilty for them, mom and dad being with them. And the one at home feels good because look what they sent me. Isn't that nice? So children coming in for surgery, being hospitalized, one of the things, especially if they've been in a hospital before, how did they act? We know some children fit into a hospital, are not afraid, and they get along. Other children, especially if it's previous hospitalizations, might have had a bad experience. And if they've had a bad experience, it might make this hospitalization difficult. So if we knew it, we could work on preventing that child from getting to that level again. Now, adolescence. Adolescents really need to be involved with their diseases. This is knowing themselves, being in charge of themselves. They are now adolescents becoming adults, right? So any sort of time where we can get like type diagnoses together, whether it's congenital heart disease or cystic fibrosis or asthma, whatever it is, put them together. Put all of those adolescents together and let them talk with each other and share each other's frustrations. It makes them feel not alone. Tanner's stages of development, you're going to see this. It's one of those, how do you remember all of these, this and that's about these 5 stages? Well, this is the way I'll tell you. Number one, it's puberty at all is going on. Age 5 is you're a female and you're a male now. All the stages have gone on. You're an adult. In between is where we start showing signs of puberty. Now, stage 2 is girls, breast buds, boys, increased scrotum. And then the next 2 are now increasing, breasts and hair, et cetera, et cetera. So which stage would it be? It's gonna probably be somewhere between 2 to 4 of which stage of puberty, because there's not and there's full. So a question would have to be one of the in-between ones. Now, adolescents are this area, they're not 18, so they don't have those 18-year-old right yet, but there's many females that come in and request birth control. What are we to say? Mother's not there. Well, we do not need parents in order to talk to this adolescent. We are going to counsel them on the benefits and risks of oral contraceptives with written and oral information, not our opinion, okay? That's how we deal with contraceptives in adolescence. Okay, Piaget. Piaget is about thinking. It's like taking the finger, putting in the mouth and sucking and say, I like it, and then find that finger again and sucking it again and saying, I like that more. So it's figuring things out. One of the first things infants figure out is once they see a toy or a object that they like, even though it's hidden, they can still find it. And that's called object permanence. It could be under the blanket, it could be behind another toy, but they still know to go looking for it. And it's good because you put them on tummy time, they're going to start to try to use their muscles to try to wiggle up and get it. Erickson. Erickson's all about the people around them. Okay? Infants is all about trust. I cry, someone's going to get me, I'm going to be fed, my diaper's going to be changed. I mean, remember, if it's at nighttime, it could be that diaper rash that's keeping you awake. So put some good cream on it, all right? Now, Erickson with school age. School age, remember, they feel a great sense of accomplishment when they do something well, whether they're the fastest runner, the best speller, the best at math, the best handwriting, whatever it is, that's my industry, my factory, what my product is, what I do well. And that's important. So, what does that mean in care? Whenever we do things for school age children, let's say they're there for a long time, and we need to give them some sort of challenge, whether it be a puzzle or something. Never choose something that they could not finish. Give them something that would take a little bit of effort, but they would be able to accomplish it. You don't ever want them to feel like they can't accomplish it. You never want to make it too hard. Erickson and adolescents, remember, they're all about me, body image, right? What do I look like? Who am I? What am I going to be? One of the things with adolescents, a lot of them won't share a lot of information in front of parents, so you can. And I've seen it all the time. Parents, could you please leave the room so we can talk to your child? All right, let's go into some of the different body conditions that go on here. So, hematology, all about blood. So, hemophilia, this is all about the child who bleeds easily, right? So, not only are we going to be knowing that this child, hemophilia, which factor are they? We need to give factor and how do we treat those things? But look about the little toddler who now is just diagnosed, has hemophilia. You have a toddler who is trying to walk and run, bouncing into everything. And if everything, those sharp edges are protected, they could cut themselves and hurt themselves. Safety. Hemophilia, toddler, it's all about safety, protecting that house, okay? Now, what if you get that hemophiliac who was outside, tripped, fell, banged her knee on a stone, and now it's big and red and swollen? What would be that treatment for that child? Well, any injury, it's going to be a RICE. Rest, ice, contain, and elevate. We want to slow down the heart rate, right? We want to ice to constrict the blood vessel, to decrease the swelling going on in that joint going on there now. All right. And we also want to put the ACE bandage around it so that we're putting pressure to stop the bleeding. And of course, elevate it, of course, stops the bleeding too. Also, they will be giving home factor, whether it's factor 8, factor 9, there's different things that they can give. Now, nosebleed, I don't know if you had it on your Saunders question this time. Nosebleed, how do we treat it? Well, number one, you ever see a child with bleeding and they feel like they're dying because and now blood's everywhere and they're screaming and running and now blood is going because their heart rate's up and they're nervous and they blood, I'm gonna die, right? First thing, calm the child down. Number two, thumb, forefinger, put it on the bridge of the nose and lean them forward 10 minutes. You lean them forward so that they're not swallowing blood back because then they'll vomit clots of blood if you let them lean back. So forward so that it can come out. All right. And if it's still bleeding, they need to go to get emergency treat, whether into an ENT or into a emergency room. Might be cauterized, might need tampons. They call them nasal tampons or something to stop that bleeding that's going on. Now you have a child, whatever condition they are. We talk about platelets being low with children with leukemia. We talk about, platelets being low with children with ITP. I mean, it doesn't matter the reason why. If platelets are low, what do platelets do? What do you know about platelets? They stop bleeding, right? They're a part of the bleeding cascade there, right? Platelets are low, guess what? There's going to be bleeding. It might be petechial rash, it might be ecchymosis, it might be a nosebleed, but it's going to have some sort of bleeding. So, if you have a patient, child, adult, doesn't matter, in the hospital with low platelet counts, what's going to be your nursing care? Part of your nursing care plan. bleeding precautions, right? Makes sense. That means no razors. They're not going to do blood draws, no IM injections. I mean, these are things we'll be monitoring closely. Sickle cell disease. How do we prevent sickle cell crisis? Well, what causes it? Sickle cell disease is caused by blood vessels that get really small, and these sickle-shaped cells can't get through. So it has to do with blood vessels being big enough or not. If they're expanded enough, those sickle cell bloods can go, those cells will go through and not a problem. There are times where we need to extra hydrate because of the situation. If we are outside in cold weather, we need to dress warmly, whether it's, putting on the thermal underwear, whatever it needs. And of course, hydrate, hydrate, hydrate. Children's sickle cell disease need to play sports. Hydrate, hydrate, hydrate. Hydrating is even the first line priority treatment. Remember, sickle cell, hydrate. Dilate the blood vessels. You're not going to have a crisis. There's going to be no clumping of the cells. ALL, leukemia. Remember, it's immunosuppressed. Remember, immunosuppressed people, whether they're ALL, whether they're any other condition. Remember, our priority is if you are immunosuppressed, that means you have the inability or a lowered ability to prevent infections. So, with that being said, these children must be in a private room if we are placing them in the hospital. We can't have another kid breathing any germs on them because they only know their own germs. It's the only thing they can fight. They have nothing to fight infection in them. Iron deficient anemia, I mean, I've mentioned this before, it's been on the cahoots. How do you give iron? Remember, iron deficient anemia is only because you don't have enough iron in the body. We can put them on a diet rich in iron, or if that doesn't work, we can give a supplement. Remember, this iron is black, it's brown, it's thick, and it will stain teeth. This is the reason why we put a straw, so it will suck down past the teeth, and the teeth will stay nice and shiny white. The other thing about iron, it does not get ready to be used to the body till acid breaks it down, stomach acid. And if you drink orange juice, which is an acid, it helps break it down quicker and gets the iron to the body where it needs it. Now, orthopedics, bones, 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 bones. Well, in many diagnoses, they have to be on meds. They have to have certain treatments, and it becomes overwhelming, and it's amazing that these children are going to put up with it as an adherence and compliance. What if you have a child who's diabetic, who does their own blood, they're 8 years old, does their own blood testing, knows how to give their own coverage, knows their diets? This is someone that you would give rewards to. This is someone you would say what a great job they're doing. And this would be a child, school age children, that if they're discharged, you give them a copy of the written instructions also, because they're the one who's in charge of their condition. All right, you have a break. Fell off a monkey bar. That's always what I hear. I fell off the monkey bars. What do you do first? Well, what is your priority? Your priority with a break is circulation, right? Neurovascular signs. So if you broke the wrist and it's swollen, you'll be checking capillary refills in the fingers. Nice, good capillary refills, you're good. And then you have time to do x-rays and set the arm the way that it needs to go. With rheumatoid arthritis, one of the ways that we can help this child keep these bones moving and keeping them exercising. Rheumatoid arthritis, the worst thing to do is to sit and do nothing. The muscles, the joints hurt, but if you sit too long, they get worse. The best exercise is a swimming pool, and I can attest to it. Go in a pool, you move all your muscles and it doesn't hurt, and you get out and you feel better because you've stretched and it didn't hurt. Harrington rods, what's that used for? That's used for scoliosis, greater than 45% curvature. These are two metal things that go, and there's the picture, on the side of the spinal column. And we take this S-shaped curve and try to make it as straight as we can because it's taking up space in the lungs, okay? With that being attached to the spinal column, it's brittle. It needs a chance to adhere well. Post-op, this is your log roll patient. Pillow between the legs, two people, hip and shoulders, and turn them over, one motion. And again, osteomyelitis, we've already talked about that. We know any infection, we need good protein, good diet. Okay, cardiac. I know this is probably the bane of all of your existence. I know it's been difficult, but let's go into some of these things. Kawasaki disease is a vascular itis. It means it's an inflammation of vessels. And our concern here is an aneurysm in the coronary arteries of the heart. So priority procedure is an echo. Is that an aneurysm that could bust? Because if it bursts, that child's dead. Because that's the coronary arteries going. That means heart's going to die. No blood's going to go to the heart muscle. So priority procedure is going to be an echo to look at that, any heart damage. Medications, how do we treat it? You want to boost their immune system because it's a virus. IVIG. And remember, this is itis, this is inflammation, this is possibility of multi-emboli in the blood system. So high dose aspirin. Why do we give aspirin? To prevent clots, to thin the blood. Simple as that. Prostaglandins, remember, this is what is open in fetal circulation. Mommy produces that good stuff, right? Mommy delivers the baby, and now mommy's supply is gone. There are times where we need that oxygen giver to the baby, and we can keep it open. Transposition of great arteries is the big one that we keep it open for. One of the side effects, actually, of prostaglandins, there's actually two: low-grade fever and bradycardia. Usually children on prostaglandins run about 100 temp. It's just because of the prostaglandins. Now, indomethacin is used when mommy's prostaglandin is gone. We don't need that patent ductus arteriosus or oxygen giver. We don't need that anymore for the body. The body's working correctly, so we need to close it. What we can do is there's medical and surgical closure. We can give medical medicine called indomethacin or Indocin, and we give it. Now, PDAs, at birth, you hear a washer machine murmur. Sounds like a washer machine, right? As you give indomethacin, you're going to hear that murmur go away. It's actually quite fun as a nurse, knowing you're giving indomethacin to this infant, and they're usually premature infants, listening to their murmur, and as we're giving it, we can hear that murmur get less and less until it's gone. A congenital heart disease child. Remember, if you have a congenital heart disease, that means your heart is not functioning properly. It takes a lot of effort to get blood around the body. So we are exhausted to start with, right? One of the big things about congenital heart defects is the inability of the heart to pump, and it causes fluid to build up into the lungs. So how do we monitor those? Well, anything with fluids, intake, output, but daily weights. With a child with congenital heart disease that all of a sudden has a weight gain, blood pressure's going down, probably heart rate is up, listen to their lungs. I bet you they're in congestive failure. They probably are going to need some sort of support, whether it's a diuretic or a digoxin or something to get that heart pumping properly. Cardiac catheterization, nursing care, when they come back, Remember, the big thing is that right groin, they've hit it, the femoral artery and vein, and it could bleed out quick if that clot moves. Remember, bleeding is your greatest risk. Remember with giving digoxin, you're going to monitor everything that you would do for an adult, but your heart rate's going to be a different number. So, depending on the age of the child, what would be a low heart rate? So, let's say 100 would be a low for an infant. So, a heart rate of 80, well, what would you do? You're going to hold the digoxin, call the doctor, and probably get a digoxin level, right? We got to make sure. Another thing with digoxin, sometimes the only thing you see as a side effect is vomiting. So, an infant, young child on digoxin who's vomiting, heart rate says okay, but vomiting, never second guess it. Hold it, call the doctor, get yourself a dig level. Remember rheumatic fever and remember acute glomerulonephritis. Both are strep infections. You need to know those. So, urinary. So, GU, urinary tract infection, most common of all infections. One of the biggest symptoms is new onset bedwetting. It's not the urgency, it's not them, touching themselves and wiggling and all of those things. No, that new onset bedwetting could be. I mean, that's another one for diabetes insipidus and mellitus too, remember, but it's also urinary tract infection. Cryptorchidism. It's when the testicles are up into the abdominal sac. Now, men, when it's warm, their testicles hang, right? When they get cold, it tends to suck the testicles in to keep them warm. So, if you're going to be testing an infant, making sure his testicles are in the scrotal sac, you need him in a warm room. If it's cold, you're not going to get a really good examination. You need it warm. Another thing is, long-term antibiotics. It could be that osteomyelitis kid, right? Long-term antibiotics because, osteomyelitis is going to be a month, maybe 2 months of IV antibiotics. Many times this is due to staph infections and they give vancomycin. Now, vancomycin is a great drug. It's also extremely toxic. This is an aminoglucoside. And what does that mean? This one is going to need peak and trough, and we're going to be monitoring this child for side effects. What are side effects of vancomycin? Ototoxicity, hearing loss, and it can kill your kidneys, decrease urine output. So, what are you going to be monitoring on a child on long-term antibiotics like vancomycin? Their hearing and their urine output. As simple as that. Now, nephrotic syndrome. Remember, this is not kidney failure. The kidneys are working, but the kidneys are being particular and they say, protein, I don't like you. And they dump all their protein out in their urine. The problem with this, protein is in your blood. When the protein comes out of your blood, it causes fluid to go interstitially. So you will be full of fluid everywhere, generalized edema everywhere. You just will be. So what we do in these acute stages where they're really puffy and swollen, we're going to be treating them by giving them back their protein. Protein, the other name is albumin. We can give 5% albumin, 25% albumin. And what this does is pretty neat. It's a huge concept here. Put protein back in the blood system. It pulls the fluid back out into the vasculature because it's trying to equalize it out again. That's osmosis stuff going on. Pulls the fluid in, goes through the kidneys, and guess what? Urine output increases and your edema decreases. How does that sound? Because you put the protein back in the blood cells and you sucked out the fluid from interstitially and poof, it comes out in the urine and it will get rid of the swelling. Many times they follow this albumin with a dose of furosemide. About 30 minutes later, let the albumin get in there into the intravascular, let it pump around a little bit, give the furosemide, okay, work, and get rid of the swelling. Now, GU again, the hypospadias epispadias. Hypospadias. We have a ventral and we have a dorsal. Where are they? Well, hypospadias epispadias, what you need to know is that this boy's urethra ended either underneath, this is hypospadias, dorsal, or ventral, or did it go on top? Epispadias. So before they're potty trained, we have to do surgery. They fillet the penis, open it up. They take the foreskin, because you cannot remove the foreskin on this child. In a Jewish faith, that might be a problem, right? We need this for the closure. And when they're done, they put a catheter in and they'll close it up. The catheter must stay there for 7 to 10 days. It makes the lumen so that now they can urinate from their bladder out the tip of their penis like normal men do, okay? So it should be done before potty trained. We don't do anything to that catheter. Leave it alone. Put it inside a diaper so you don't get urine everywhere. That's all you do with that thing, okay? Now, Wilms tumor, nephroblastoma, something to do with the kidney. Remember, the big thing with Wilms tumor is it's very fragile. Just manipulation and touch can cause little microembolus to go and metastasize in the peritoneal cavity. This is a tumor. They will never, ever, ever do a pre-op biopsy. Why? That hole makes a port for that tissue to get out and the cancer to metastasize to the whole peritoneal cavity. It's encapsulated. Leave it there. They go in and they take it out. Big thing is leave it alone, do not touch, pre-op, and then no biopsy because we can't. Chronic kidney disease, CKD, has problems with vitamin D and calcium and erythropoietin, right? Kidneys, remember kidneys, what do you think about? Potassium, erythropoietin, vitamin D's, calcium, these are all part of kidneys. So if you have chronic kidney disease, you're going to have problems with bone and bone growth because of that erythropoietin not there and not having enough calcium and vitamin D. So how would you decrease the amount of bone, dystrophy or irregularities or not bone growing? Well, we would give erythropoietin sub-Q, right? Increases red blood cells there. We're going to give calcium and vitamin D, watching their levels, making sure they have enough so as they grow, they have the vitamins they need to grow properly. I've already told you glomerulonephritis or acute glomerulonephritis. It's a strep. Again, we'll treat the strep infection. Testicular pain is a true, real emergency. The last 10 years of my career, I worked in an ER. You have a young boy, no matter what age, from 2 to 20. They come in testicular pain. They are high level, red chart, which is top priority. They go right back into the ER because it could be a torsion. We're worried about that testicle twisting and then letting this child not ever have a baby. So it is a true, real emergency. Now, respiratory. Croup, if not treated, can turn into epiglottitis. Just remember that, okay? So, croup, it's the swelling, it's upper airway, it's the epiglottis, it's the oropharyngeal stuff, the swelling up. You will never forget what this cough sounds like. It true and real sounds like a seal barking. It's very loud. Louder than, different than most. Now, many times croup children come in, they need a steroid, they go home, they're fine. There are times where it is so swollen, they might give what we call neurasthenic epi. Now, epinephrine can be given in a sub-Q injection. We know that, right? Res- That's your EpiPen, but it can be given in an aerosol, just like albuterol, all right? And we can give that, and it puts this epi right on the area that needs decreased swelling. This is the big precaution. If that child goes home that's had that racemic epi and now they can't swallow, what are they telling you? Swelling is increasing there, you're in trouble. Get them back to the ER now because you probably are going to epiglottitis. All right, now you see how I started with that. Now, epiglottitis. The epiglottis now is covering the trachea and air can hardly get in there. This is a child that, if you can imagine, this epiglottis is covering the trachea, and maybe there's one little piece, right? If you hold your head right there, oh, I can get air through there. This is what you'll see. They'll be up on their arms, they'll be leaning forward, and they'll be trying to get air. They're going to be, talking garbled, drooling. This child, you better have at bedside a tracheostomy tray and an intubation tray. This child could need it because their airway is going. There is none. Remember with asthma in children, there's all different sizes of masks and spacers. Remember that spacer is great. We can take little toddlers and they their little spacers on and we'll give their own, we'll squirt it and they'll breathe in and out. We make it a game out of it just because of the spacer. They can breathe, push it and breathe in. Most people can't do that. Adults can't. Many of them do have spacers also. RSV, respiratory syncytial virus. This is a virus. It is a common cold for you and me. With an infant who's having a hard time swallowing and breathing, this is a big deal for them. We don't want them to get that, especially if they have an underlying condition, congenital heart disease, cystic fibrosis, any underlying disease that they don't need anything else to make it difficult. We need to prevent these young infants, and only the first year of life this is given, is Synagist, and it's given monthly. Now, knowing if we're getting these immunizations, you get two infants that both had RSV vaccine, they can go in the same room. You get one who's had vaccine, one not, you cannot put them in the same room with RSV. Remember, you're not going to expose one to the other. Again, big deal for placement, knowing how to place patients. In infants, how do you know a child is in respiratory distress? And it is different from adults. With adults, we have, tachypnea and we have dyspnea and we have all those lung sounds, right? Infants, I can see from a mile away. Nasal flaring, and at the end of a breath, you hear a that's called a grunt. So that is nasal flaring and grunting is specific for infants. You see that? That child's about to crash. This is a child I would take from triage immediately back to the trauma room. That's how serious it is. Cystic fibrosis. Why do they need enzymes? Why do they need chest CPT? Well, cystic fibrosis is mucus that clogs lungs. It also clogs the small intestines tract and it has a problem with pancreas and fat digestion. So, CPT is needed because those lungs are full of this thick mucus. I say if we don't remove that stuff, it's like petri dishes waiting for bacteria to grow on them. I mean, they have chronic respiratory infections because of all of this mucus in there. So chest CPT, we do it, remember, before meals. We give an aerosol of albuterol first, open up the lungs, give chest CPT, get rid of it, and then we can eat. We wouldn't do it after because they will vomit, all right? Also know that with the enzymes is these children and they become adults that cannot absorb fat vitamins. So with that being said, pancreatase is given to help with this absorption. Remember, these children will be chronically with fat vitamin depletion because they're not absorbing fat either. Remember, it is tested with a sweat chloride test. As I said, if you licked an infant, and I'm not telling you to do this, but if you happen to, this child would taste salty. I mean, if you told the parent, if you tasted the skin, you're going to taste salt, and they probably would just to see. I'm saying, yeah, this is the salt that's coming through. This is why they need salt in their diet. They're losing it. And we know albuterol is your rescue. We give that when they can't breathe. Now, gastrointestinal. I mentioned it earlier with the infant and not sleeping at night, but let's say diarrhea. Generally, diarrhea. You get a child in, especially if they have a diaper on. This is one thing as a nurse, always check, their buttocks. Do they have breakdown? Do they need any creams or lotions or et cetera to help them? That's part of the care, not just giving them fluids or checking electrolytes or intake output daily weights. No, remember, it's also making sure that diaper rash is good. When you have a child in abdominal pain, what's some of the most important things to ask? Well, where is the abdominal pain? Not how long, not if you had vomiting, diarrhea, how bad's the pain. If it's right lower quadrant, now I'm going to examine even closer, right? If it's umbilicus, it's something else. If it's left upper quadrant, well, there's not much there but gas. So according to where it is will depend on your care. So let's look at the status post-abdominal surgery. Let's call this the child that had that the tumor, that nephroblastoma removed, right? That nephroblastoma has been removed. So it's a kidney. I've got to go through all the intestines to go all the way to the back because that's where the kidneys are to get these things out, to get the tumor out, right? Post-op, this is a child that you're really going to have to monitor for GI. Is there GI? Do you hear gas? Are we hearing bowel sounds going on? Are we passing gas? Have we had stools? Really important. This is the child that can develop paralytic ileus. What are the signs and symptoms of paralytic ileus? Severe colicky, abdominal pain, nausea, vomiting, abdominal distension. And that's because we went through all those intestines, pushed them away to be able to get that Wilms tumor, that nephroblastoma out of the way. Pyloric stenosis. Pyloric stenosis is the pyloric valve in the stomach, which empties the stomach into the small intestines, is thickened, and milk can't go through. So what happens? Infant's a normal child. Drink, 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 burps. Well, everything's good, good, good. All of a sudden, the stomach says, oh, I've had enough, and vomits. But not just a little gurgle down. I'm talking turn the child around 10 feet away, see a garbage can, point it to them, and they will hit the garbage can 10 feet away. And I'm not exaggerating. It is projectile. It's the most forceful vomit I've ever seen. I've never, these little tiny little 7 weeks, like they say 3 weeks to 3 months. So usually that's 7 weeks is when I see them, 7 to 8 weeks. These little infants that are like 2 months old across the room. That's how you know that it's pyloric stenosis and not just GERD reflux. Reflux is a dribble. Pyloric stenosis is across the room. Now, once you see that projectile vomiting across the room, take your hand, put it underneath the xiphoid process, and there's going to be an olive-sized mass there. I call it a marble. It's sort of hard, and it is about that big. It is quite significant. You should, like, a size a dime, and you should be able to feel it there. That's your diagnosis. Yes, the child will go have an ultrasound. They'll do surgery they'll start feeding that child postoperatively, and usually there's no recourse long-term problems with that child. Okay, intussusception, treating a child that has an intestinal problem. Intussusception is when that bowel sucks into each other like a telescope, right? What's going to be our treatment? Well, what do I know about intussusception? I know this child, the intestines suck in. I know that they're in intense pain, screaming, kicking, yelling while that is sucked in there. And I know if it's kept in there, it's going to swell and they're going to have surgery, not just be able to by itself come apart or with an air or barium enema pull it apart. So this child, we need to, number one, NPO, nothing more in that GI tract. And why do you think we need IV fluids? It's because it keeps it hydrated. You want to keep all the tissues hydrated so we can pull them apart easily. Swelled up, right? Swelled up, hydrated, we can pull them apart easier. And that's why. Now, GERD. This is one of those things, choosing a food for GERD. If you have gastroesophageal reflux disease, you don't want chocolates, you don't want spice, you've got to eat very bland food. So what would you choose? Well, let's say you had a pizza and you had a hamburger and you had an ice cream and you had a sugar cookie. Guess what? I'm going to do the cookie. That's the least of all evils. And that's where you need to look at those type of questions, okay? The least of all evils, what's the best? Cookie, yeah, should they have cookies? Should they have sugar? Is it the least of all evils? That's, again, what you look at. And there's another diagnosis that I have mentioned. Oh, we don't really cover it really severe. It is in one of the cahoots that you do see, and it's biliary atresia. And I just want you to understand, whenever you think of biliary, you think of liver, right? What does a liver do? It produces bile. What does bile do? It digests fat. If you have an atresia, that means no opening, A without. That means no connection between the liver and the common bile duct and the small intestines. There's no connection. What's going to happen to all that bile? You're going to look like you have hepatitis, right? You're going to have yellow eyes, jaundice, and you're going to have that tea-colored urine. Another thing is there's no bile in the stool, so it's going to be a pale colored stool. So does that make sense how you would figure out a biliary atresia? It's about fat. It's about your liver. What does a liver do? It's bile. If you don't have bile, what are you going to see? Where does the bile go? What's going to happen? That's what that is all about. Now, neuro. Sometimes it could be simple things like you have a child who's complaining of ringing in their ears. What do you do first? Well, if I'm ringing in my ears, number one, I'm going to look in the ear and see if there's anything in there. I have found roaches. I have found crayons, earring backs. I have found there was one bee, but it was dead already. Thank goodness. And the one roach was actually alive when they came in, and they could feel it moving in their things in there. Now, ringing in the ears, they may not feel that, but it could be something in there. Always, number one, look before you do anything else. Whenever you have any symptoms of meningitis-like things, headache, photophobia, neck rigidity, all of that, remember, you're going to do a lumbar puncture. And why? Well, is it viral or is it bacteria? It's treated differently, right? Remember with seizures, it was on the last exam. Remember all about safety, 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 safety. You're going to be safe and teaching parents to be safe. Febrile seizures. Remember, parents who have children with febrile seizures, and my firstborn grandson had febrile seizures, and I know what his mother went through. And it's like she always had a thermometer, Motrin, and Tylenol in her purse at all times. And she was maybe 8 times a day was checking temperatures for the first 12 years of life. I mean, and I'm not exaggerating. That's how she went with this. Remember, febrile seizures, they usually outgrow or they decrease with age. That's what you have to know about febrile seizures and what you should, tell the parent. If they're having a seizure again, remember, it's safety. And remember, febrile seizures, you can't always catch them. It's a zero fever, 98 goes to 101 in 20, 30 minutes, and you didn't catch it. It doesn't mean you're a bad parent. Remember myelomeningocele. This is when the meninges and spinal column is pulled of the lower extremities and up and out on the lower back. What is our big job with that? Well, number one, keeping it clean, sterile, protecting skin integrity, right? Remember, it pulled nerves. So be careful with urine and stool. And know that this child will forever be latex allergy. Now, today we don't have many latex stuff for children anymore. It was a saving grace for me because I ended up with a latex allergy in the early 80s when they first came out with everybody had to wear gloves, the HIV scare, right? And I ended up, and my hands would swell up and turn red and itch to the point of I'd itch my skin off. So, with these children to prevent it, just because, number one, latex allergy, many of them require urinary catheterizations every 4 to 6 hours because they cannot urinate by themselves. The nerve isn't there. Remember, there's sensory and there's motor damage there because those nerves are pulled up. Now, Duchenne muscular dystrophy. Remember, it comes from mommy. It's a mommy recessive trait, and this is boys. We usually figure it out about age 3, but it's the diagnosis of it that can be difficult. These children usually are cognitively delayed. So there are some delays with them to start with. Usually they're a little overweight too. They can start to walk, and all of a sudden you'll start seeing them falling down, and you'll start seeing their muscles getting weaker. Those are the signs and symptoms. So they bring them in and they do something called electromyography, an EMG. And what this does, it delivers little electronic shocks to muscles, and the machine measures how strongly the muscles responded to the shock. That's what it does. Well, it's like you ran a marathon. These children come back and they're in pain. Make sure we offer them some acetaminophen, ibuprofen, something. And rest assured to the parents, of course, that it's only temporary. It's because they have stimulated these muscles. Remember eye injuries, anything in there, and you've got to put a patch on. Remember, patch both eyes and get them to ophthalmology or to an ER that has pediatric ophthalmology. Get that thing, so they're not moving their eyes around. It protects it. Nystagmus. Remember, anything with eye problems, do that 6 cardinal positions of gaze. That can help you. Hydrocephalus, we mentioned it. It's that increase in head circumference, and many times hydrocephalus cannot be treated with anything but a shunt. And it's called a ventricular peritoneal shunt. And here's a great picture, and it shows you how it goes. Goes in the head, behind the ear, and through the front of the body into the peritoneal cavity. Now, many children live with these things because they can't deal with the fluid in their head, so they have this VP shunt. But children grow. Sometimes they disconnect. So that means fluid is now starting to build back up in the head. So what are these kids gonna show as when they come in? Well, they're gonna have a headache, increased intracranial pressure, and they're gonna be vomiting. How do we treat it? Well, of course, we do the x-ray. It's called a shunt series. Figure it out. Yep, that's what it is. And we do surgery. How do you know the surgery worked? they stop vomiting and don't have a headache. That's the answer many times. Make it as simple as that. Endocrine. One thing I have in every lecture, I think I've mentioned, children in height and weight measures so much. Every single visit that we have on children, we always, always, always do a height and weight on a visit. Urgent care, ER, doctor's offices, always. Adults, we don't care anymore, do we? I could give them any number. I weigh 200 pounds. Yeah, no, I don't. But I could say that and nobody weighs me. Children, yes. And the reason is, for instance, in this case, we're looking at that growth hormone. Are they growing the way that they should? And it can also look at your thyroid hormone, many hormones that can look at, nutrition, etc. But especially with hyperpituitarism as related to growth, we measure it by height and weight. Remember, the parathyroid is not a thyroid gland, and the parathyroid regulates calcium. Calcium, magnesium, both of them have to do with muscle strength and spasms. You need calcium for muscle strength. So if you don't have enough hypocalcium, not enough calcium, your muscles are going to weak. If you have hyper, the muscles are going to be tense, right? They're going to be in tetany, or be tightened like that. With children with DKA, know that an infusion pump is a great choice when a child can monitor it. An age, it's not really an age, it's when a child, 8, 10 years old, when a child can be able to adjust the rates, take their own blood sugars. Also, knowing that we take those all of the insulin you know injections, and we do the rotations, the arms, the legs, the abdomen, teaching those sort of things, knowing that a child with diabetes, making sure you keep them normal, let them play sports, check their blood sugars before they play. If the blood sugar's not good enough, give them a snack before they go out. I mean, it's that sort of monitoring. So again, as I said, diabetes, rotate your injections. Now, children and everybody, adults, need to know what a sign of hypoglycemia is, because the treatment is so simple. It's getting a packet of sugar, getting a soda, getting something in them, something with sugar in it right away, right? But these are the symptoms that you would be looking for: sweating, shaking, headache, and nausea. Those are classic signs. Give them a sugar candy, give them a glass of orange juice, glass of milk, whatever they need. There was one question that had to do with thyroid hormones. And the only thing, remember, I take these off of the results on your HESIs, and it had to do with thyroid and hormones. And the only thing that I could figure out with is just know the relationship between TSH and T4. If one's high, the other one's low. And conversely, if this one's high, the other one's low. That's just knowing that thyroid hormones do work upon each other. They're not both high. You're going to see them
I know I
on
do it
your.
that same day back on.
Now, an adolescent, let's say you have an adolescent who is the BMI is really high. So you're big, right? Let's say you're 95%, 90%. Now, what do you might suspect? Now, we can always just say they're just obese, they're overweight, but remember, there's other things that it could be. So if their BMI is high, think about checking for diabetes, checking their hemoglobin A1C. If they're having symptoms like increased urinary output, increased hunger, increased thirst, all of those things, rule them out. If they're increased urination, rule out that urinary tract infection. Anything else you see. So always rule those out. And then there's some common kids' disease. We didn't get to go over a lot of them, but let me hit you with some of them that you might see. Impetigo is an extremely contagious disease. It is a staph infection. And you need to make sure you wash your hands with this. So it's oral and topical antibiotics. And you should not like pop these fluids because it will spread. My grandson Christian had it on the back of his leg, started this big and ended up like the size of my hand. And it was painful and oozy and juicy. And behind the knee, it kept cracking on him, the poor thing. But we treated it with oral and it's fine, and there's even no scars. Now, conjunctivitis. Remember conjunctivitis, kids are always spreading things, hands and face and eyes, and it's going to happen. Remember, we're going to put some sort of eye medicine in there to treat it. Remember, if you're putting an ointment, whether you're a child or an adult, always let them know that ointment is going to make their eye look blurry at first. And once it melts and gets in there, the blurry will disappear. Can you imagine? This kid could get really, oh my God, I can't see. What did you do? Oh, it's going to get blurry. Let me see how many times you have to blink before it's not blurry anymore. That's all you need to do. Again, you wash it with just warm water from the inside out, both sides, and apply the ointment. And I always tell parents, change the pillowcase every time the child lays down. And that's in no textbook. I'm just telling you that's what I've always said because they'll keep spreading it. Now, ticks. Children like to go out and play in the woods, and they like to play out by lakes and tall grass and all that sort of stuff. And all of a sudden, you see a tick and it came out, and now they have a fever. What do you need to do? Well, the first thing you need to do is check the whole body. Is there any other ticks anywhere that you didn't see? And if we're seeing that, we start seeing, the circle rash going, to get to the doctor so we can get some antibiotics to treat that. Tetanus, stepping on the rusty nail, right? Well, as a nurse, what do we need to do? Well, you need to clean it with soap and water. Easy. And always, we tend to like, let's say they get full-blown tetanus with all of the respiratory stuff going on. We tend to forget about where it came from. Always remember the wound, clean it with soap and water, put antibiotic ointment on it. Always with tetanus, you check their immunization status, and we're going to give boosters. Absolutely, we'll give boosters. Some common kid stuff, chicken pox. Remember chicken pox, it's 2 days prior to the onset of rash, they are contagious. So you get chicken pox, you didn't even know the other kid had it. And 2 days later, they say, oh, by the way. And they are contagious until all the lesions are crusted over. Remember with head lice to go in and check the follicles because there are little eggs in there, and you're going to put on the shampoo and a fine tooth comb and get it out of there, all of those little eggs. Remember otitis media. I think one of the most common of all the things that children get. They're always getting ear infections because all the mucus goes up into their ears. How do we decrease the amount of ear infections on children? Well, if they're breastfeeding, you're getting mom's immune system. So that's always number one. But number two is smoke. This is one of the reasons why we don't smoke around children. ADHD, you have a child, attention deficit hyperactivity disorder. These children, they're they're going 100 miles a minute, right? They don't know where to go, how to take and control themselves. They don't. It's not their fault. It's just part of their condition. So there are medications that can be given. I mean, some parents decide yes, some not. No, that's a choice. But some of the things that we as nurses can tell these parents is to have in their home some sort of organizational chart. What do you do on what day? What needs to be done? So they can look and see it and check it off. Also, consistent, routine, right? That helps them. They know what to do when it's going to happen. So they don't have to think by themselves. And because now they're in school, they're coming home with homework, one place for homework. Because if they do it anywhere, it might be then they're playing a game. They know this place is for homework, they'll just do their homework there. And I went over nosebleeds already. So let's go into some infectious disease. Remember, safety, infectious diseases are things you're always going to see on HESIs. This is part of it. NCLEX, they always love these things. So a child that has a low neutrophil count. Well, what is a neutrophils? Neutrophils are white blood cells. What do white blood cells do? They fight infections. If you have a child with a low neutrophil count, and let's say that low neutrophil count child also has a fever, this child's going to go into septic shock very quickly. This child is your priority, right? Remember that neutrophil count less than 500 means there's nothing. There's no neutrophil count. So again, and it doesn't mean that the child has to have leukemia or any other disease. The child could have a low neutrophil count due to some infectious process. Again, that will be your priority because there's nothing to fight infection. Remember, in the hospital, infection control is all about washing hands, using proper equipment. Um, and the one thing that I think is you take these parents and these children, you put them in a room in isolation because of respiratory, and you turn around and there's the parent and the child standing at the nurse's station. And you're like, we need to bring you back to the room as I'm putting a mask on myself, right? And getting them back into their room and let them know why they can't come out. They need to protect the other children and staff and other visitors. Remember, immunosuppressed children. The big thing is we want to make sure that they don't have infection. One of the biggest ways to do that is just as simple as taking a temperature. Immunizations on infants are pretty rough, especially that 2, 4, and 6 months. There's what, 4 different immunizations we're giving. So one of the things that we can do is getting a cool pack, not ice, a cool pack, and putting it on the areas. Using the acetaminophen ibuprofen for an older kid, older than 6 months, but acetaminophen Tylenol for children less than 6 months. And the other thing is pedal the legs, like put them on their back and move their knees up and down like this. And that makes the muscles move and should take some of the pain away in those thighs. Another immunization they like to talk about is MMR. We give that about 12 months. And the second is somewhere at 4 to 6 months. So 4 to 6 years, that's before school. Remember rheumatic fever. Remember everything can be turned around. Even that chorea, those sudden aimless movements, all of that can be turned around and be gone. The only thing that cannot be turned around is heart valve damage. Now, I had one HESI that had 4 acid-base questions on it. They're going to ask you if they have diarrhea. They're going to ask you if you had vomiting. They're going to ask you if you have hyperventilating. What are those types of acid-base balances? Now, let me give you some hints. When you vomit, what do you vomit? You vomit stomach acid. So you're getting rid of acid. What is left? Alkaline. So you're vomiting, you are in metabolic alkalosis because that's all that's left is alkalosis. If you're having diarrhea, all of those enzymes for digestion are alkaline. So you're diarrheaing alkaline stool, okay? What is left? Acid. Plus it's sore too, right? So, and then just knowing respiratory alkalosis is hyperventilating. It's when you keep blowing out all your air. Those are things that you do see here. Remember, one of the things that with respiratory alkalosis and hyperventilating, it's part of what we do with Kuzamol, right? We're trying to decrease, that acid and that pH in DKA is like 7, 6.9, the pH. And do this respiratory alkalosis is trying to bring up that pH. It's trying to work for their own body, but it doesn't always. So this is it. Just remember, in conclusion here, remember to read the question. When you think you have the answer, go back and read the question and make sure you're answering what the question is asking for. And this is the most common mistake that students make. I wish you all the best luck. I hope that you do well. Let me know how you do. If you need anything, you let me know.
Thank you, Professor.
You.
Thank you.